Sir, can we share? Is it working?
Yes, sir, it's working. The YouTube link. Now I'll make you host back, sir. You make us co-host.
Okay, sir.
Yeah, if co-host option is there, it's okay. Otherwise, I made you host, sir. So
Okay,
I'm
sir.
calling Sri Krishna, sir, once. Yeah,
Sure, sir.
right, sir.
Yeah, it's okay. My timing is still 4:30.
Sir, Sri Krishna, sir, welcome, sir.
ఎవరికి అనిపించట్లేదు
సార్ మేడం జాయిన్ అవుతున్నారు కొద్దిసేపట్లో ఇది మనం లైవ్ ఇప్పుడు యూట్యూబ్ లైవ్ లో ఉన్నాము.
ఆల్రెడీ లైవ్
ఇట్స్ ఆల్రెడీ లైవ్ కనెక్ట్ చేశాను. ఇంకా ఇది అయిపోయిన తర్వాత ఒకసారి మాట్లాడదాము మనము.
Krishna sir, good afternoon.
హాయ్ నితిన్, హౌ ఆర్ యూ?
All well, sir. How are you?
Fine. How many still more we have lectures?
Sir, 4 more, sir.
4 more, huh? Okay.
Yes,
I
sir.
think by January end.
Yeah, sir. Then we will plan a hands-on workshop specifically for Pacman at a cost which we approve, like 500 or 700, just to have a float hands-on training.
Very good.
So that will be economical and easier for everyone to follow. Because I think at this moment some reservations by some people is on the money part, which probably we will be able to handle, probably we will not be able to handle. But that way, at least the purpose why we started this will be done.
It may not be possible in this Pedicon time, no?
Pedicon, yeah.
Initially we thought that, but
Pawan sir mentioned ki we can try, but we will try, but I am not very hopeful now anymore, because those who have to reserve from outside Hyderabad have already reserved their tickets, lodging, everything.
Correct,
So
sir.
cost itself will be a lot of burden.
as such Pedicon itself is a 4 days, 6 days event. So everyone will be tired because they look after only 2 or 3 days and they have different plans.
Sir, Nitin sir, madam has not yet joined. I think will you call once, sir?
Just call her once.
Sorry sir, एक call आ गया था. Prabhjot madam is facing some tech problem, sir. I will message her once again.
Okay, sir. Okay.
Yeah.
సార్ డైరెక్ట్ జూమ్ లింక్ షేర్ చేయమంటారా పార్టిసిపెంట్స్ తో?
అలా వద్దు, అంటే కొంతమంది వీళ్ళు చేయొచ్చు, మన టీసీపీ వాళ్ళకి చేయొచ్చు, కానీ ఎందుకంటే జూమ్ వాళ్ళు స్విచ్ ఆఫ్ చేయకపోతే డిస్టర్బెన్స్ వస్తూ ఉంటుంది.
Good afternoon, sir.
గుడ్ ఆఫ్టర్నూన్.
Hello, madam.
Hello, sir. So should I start, sir, or do you want to?
Yes. You can start.
Okay, sir.
We'll give introduction
Oh,
first. Pawan, we'll start.
So Pawan sir, for some reason, is not in the participant list. Probably.
Okay, we'll start.
Yeah, we'll
I'll
start, sir.
start. Huh?
Yes, sir.
Okay. Good afternoon for all, and I welcome everyone for this Pac-Man series. That's Pediatric Acute Care Management series lectures. It's a certificate course. Wonderful topics are given every time with experts in that particular field are giving their lectures and their practical experiences also. And this is a Royal College of Physicians Australia is we are doing under this Royal College of Physicians Australia. It's a free certificate course. And after this program, we are going to all this series. We are going to have the small practical session and followed by an exam also. And small then based on that, we are going to give certificates. So today particular topic is a neurotrauma. This is usually for pediatrician, it is less observed. To be frank, I can say that it is a less observed or less read topic, even though this is quite common. Even the small children, frequently they do get head injuries, but our approach towards it, how to proceed, all these details are definitely needed. Sometimes it can be very dangerous too. And on the other hand, neurotrauma, there are many other diseases also involved in this. So in this today, we have very an expert, Dr. Prabhjot Kaur. Hello, Dr. Prabhjot Kaur, who did DM Pediatric Neurology and is going to enlighten us about this particular topic. And Dr. Nitin?
Yes, sir.
Dr. Nitin is the coordinator, course coordinator, who is arranging all this total series. Just over to you once.
Thank you, sir. And I am overtly in gratitude towards IAP TCB, all the office bearers, specifically Pawan sir, Sri Krishna sir, and for their guidance throughout the series has made it a remarkable academic event. And we will be doing our hands-on workshop like Sri Krishna sir has said. I also would like to welcome Prabhjot madam for taking out time. So without further delay, we will start the session. Ma'am, to you.
Yeah,
Thank you,
sir.
Nitin.
Make madam spotlight, sir. Spotlight.
Pawan sir, spotlight sir. Okay.
Yeah. Madam को spotlight करो, sir. बस. Yeah.
जी,
Thank
sir.
you, sir. Thank you, sir.
Thank you, Sri Krishna sir, Pawan sir, and Nitin sir. So I think I'll start with today's topic. So basically, we are going to talk about the mandate was to talk about the emergency management of neurotrauma. Basically, neuroradiology as well as part of it. So we will look through these both of these things. So predominantly, I'll be talking about how to evaluate a child when he or she comes to us in the ER, and what is the role of imaging. So predominantly, it is going to be more of a clinical kind of a sensitization, what to do when we have a child who comes with a history of trauma. So whenever we have a child in the ER who comes with the history of head trauma, so usually whenever we have a child in ER, always the goal of the treatment is initial stabilization, and then try to see routinely we look at the history at the examination, and then we talk about the investigations. But when we have a child who comes with trauma, usually upfront we know the child has had a trauma. So usually parents will come and tell that, okay, my child fell from the roof or fell from the bike, or we were involved in an accident. So our approach changes a little bit. So we want to obviously stabilize the child as soon as the child comes to the ER and the parents tell my child has had a trauma. We want to see what is the extent of involvement, and we want to have focused examination and treatment side by side to prevent any long-term neuromorbidity and to intervene as early as possible. So whenever we have a neurotrauma, the first thing that we want to know is that what was the injury and is there any involvement of us, any indications to suggest that the injury is a severe injury. So we should ask, when was the injury, what was the timing of the injury, what was the exact type of accident that happened, was there any direct force which was acting on the head, what was the position in which the baby was found or the child was found if it was not directly witnessed, and what was the baby's or child's immediate state of consciousness? Did he respond to his name? Was he looking at you? Was he making eye contact or not? And there are a few things which might indicate that the baby has undergone a severe mechanism, which includes a motor accident in which the baby has rolled over, or there's a death of another passenger. If there was the baby is walking on the road or was cycling and it was struck by a motor vehicle, if there's a fall which is more than 1.5 meter for the child who is more than 2 years, and if the head was struck by a high impact object. So in these situations, we know that there's a significant risk that the baby might have undergone a neurotrauma injury to the head as well. And then again, there are some clinical features that we need to ask. Was there any loss of consciousness, or did the baby have any impairment of consciousness? Was the baby confused? Was he not recognizing family or caregivers? And how long did it last for? Were there any abnormal behaviors which were associated, which includes agitation, confusion, or drowsiness, any associated headache, nausea, vomiting, other injuries? And does the child remember the event, especially for older kids? So most of these things, if we see, most of the times when we get kids who come to the ER, we will ask for these things because these are the things that usually help us to plan our further management. So as always, fact in the emergency has to be airway, breathing, and circulation. We need to check whether the airway is patent or not, is the child breathing or not. In all trauma cases, it is better to put a cervical collar. It should be a little.
Only Tuesday.
We should be a little mindful that it should not be too tight. It should not impair the circulation. If the baby is not breathing, we need to secure an artificial airway, which may be an LMA or a mechanical ventilation. We need to check all the peripheral pulses and BPs, at least the peripheral pulses immediately, check all the blood pressures and look for the age-related cutoffs, and fluid resuscitation as and when is required. So whenever we talk about airway, in a child who has come with neurotrauma, there are some specific indications for endotracheal intubation. If the child is not having a gag reflex, if we want to protect the airway and start mechanical ventilation, or if the baby is not breathing well. Now, what precautions we have to take while intubating is that we have to ensure have had a cervical trauma, and excessive mobilization or extension of the spine during intubation might result in an underlying spinal injury as well. For sedation, we can use midazolam, fentanyl, IV lignocaine, and muscle relaxant without hyopenton. And we should keep fluid resuscitation ready. So once we have ensured that the child is breathing, the airway is patent, and the child is not overtly in shock, and then we should have at least a basic immediate general physical examination checkup. So we need to check the pupils immediately. We need to palpate for any palpable skull fractures or bleeding. So we need to look for signs of fractures on the base of this. Many times if there's a palpable bleed or possibility of an underlying skull fracture as well. So there are telltale signs for that. If the child has a hemotympanum, if the child has a CSF otorrhea or rhinorrhea, there's a periorbital bruising or raccoon eyes, or if there's a bleeding over the mastoid area. So now these indicate that there's a fracture in the base of the skull, and these kids will usually be triaged to undergo early imaging just to assess what has happened. Now, CNS examination wise, we can have a CNS profile that tells us that how is the child doing. So first and foremost, we test the GCS, which is the Glasgow coma scale. Now, there are a few other scales also which are routinely used in neurological practice, which includes the AVPU scale or the 4 scale. But the GCS scale is the one scale which has been developed and probably has the best validity for kids or adults who undergo trauma. So in the GCS, we already look at the spontaneous eye movements, the muscle response, and verbal response. So we'll go. We need to look at the respiratory pattern. We need to look at the pupillary responses. We need to look at the oculocephalic or the oculovestibular responses, which is the doll's eye response or the oculovestibular response. While sometimes the doll's eye might not be tested if we have a concern for a spinal trauma. In such cases, we can consider oculovestibular responses. Many times it might not be possible in the ER. We should look at the corneal responses, the deep tendon reflexes, and the skeletal muscle tone as well. So Glasgow coma scale is something that all of us are very well versed with. So it is a standard scale which looks at the eye response, the motor response, and the verbal response. And it has been suitably modified for kids who are less than 4 years because few things they might not be able to speak, especially the verbal response is maybe a little different compared to the older kids. We have to the thing that we need to understand here is many times we get confused to how to assess a response. Now, if a child is commands, it is very easy that the child has a motor responsive scale of 6. Now, after his movements or is not obeying to verbal commands, we need to give pain stimuli. So where all can this pain stimuli be given? It can be given in the supraorbital ridge, it can be given over the nail bed, it can be given over the sternum, and it can be given over the temporomandibular joints. Now, once we are giving this response, the thing that we need to assess is the child making a purposive movement to remove the noxious stimuli? In that case, he is localizing pain. If he's just withdrawing or making a non-specific movement to kind of pull the limb back from the painful stimuli, it is a withdrawal of pain. Beyond that, there might be a stereotypical flexion response to pain or extension response to pain, both of which are not good responses. They indicate significant brain damage which has happened. So motor responses can be normal or localizing, or the child is withdrawing, or the severe phenotypes include decorticate, in which the upper limbs are flexed and the lower limbs are extended. It includes that the injury is above the brainstem level, above the midbrain level, and in more severe cases, there might be complete extension posturing. Now, why is it important to look for this or to observe this? Because not only is it a part of the GCS, but also presence of severe phenotypes, no response or posturing or flexion responses indicates upfront only that the neurotrauma has caused a significant involvement of the brain and probably it is life-threatening. So this child needs to be urgently undergoing a mechanical ventilation, neuroprotection, as well as imaging to see if there is something that we can decompress or the bleed is there, we need to decompress it, or we just need to do a craniotomy. Now, looking at the GCS, it helps us to classify the severity of brain insult. 14 and 15 are considered as mild TBI. Something between 9 to 12 is a moderate TBI, and less than 8 is a severe TBI. So any GCS less than 8 will usually require mechanical ventilation in a child who has come to the ER with trauma. So the second thing is pulmonary response. Now, this is something which is trauma. If the pupils are okay, we know that there's no major herniation syndrome going on right then. If it is asymmetrical, it might indicate an early herniation. It is important to pick up early asymmetrical pupils because at this stage it is still reversible. Our medical management like IV mannitol or 3% saline and other measures like head end elevation, hyperventilation are probably going to work at this stage, and we can buy time till the time a neurosurgical intervention can be done. And if it is absent or bilaterally pupils are dilated, it means that probably a herniation has already occurred. And at this point of time, probably a surgical intervention might not help. So of all the pupillary responses, if you have bilateral pupils, it might indicate a small bleed in the pons, which is usually not life-threatening. In case of midbrain involvement, we may get bilateral mid-positioned fixed pupils. But the most important in trauma patients is something like an asymmetrical pupil in which one pupil is dilated or not reacting and the other. So it indicates that the side of the brain on the side which the pupil is dilated is herniating downwards. So it is a very, very important. Next important to look once again maybe a What is the most important things to look up for the ataxic breathing, in which there is a very, very irregular kind of a breathing, which indicates involvement of the brainstem. And if the child is not breathing at all, it again indicates the localization to a ventrolateral medulla, which again, both of these things result in a life-threatening event, a cardiac arrest, few minutes or some time down the line. So these needs to be looked for and actively managed early with anti-raised ICP measure. So looking at the herniation syndrome, so mostly kids, this is a major worry. Whenever we have a child with neurotrauma, we are worried whether the child can go into herniation or not. Do we need to do an immediate imaging, and do we need to take an immediate neurosurgical consult and intervention? Do we need to decompress this child? So herniation happens because our brain is a tight compartmentalized area. And whenever there's a bleed or swelling in one area of the brain, it tends to push the brain out, and the brain tends to go through or push through the foramens which are available to it. So the common kind of herniation that we see is a uncle herniation. Let's say there is a bleed on one side of the brain, it will cause more pressure and it can push the temporal lobe downwards. This uncle herniation is what causes unilateral fixed pupil. If there's a large bleed, there's a large subarachnoid hemorrhage, there's a diffuse concussion, it can cause a central herniation, which means both the hemispheres of the brain are trying to push down through the transtentorial foramen. So if we look at the type of herniation syndromes, again, the size of the pupil and the respiratory pattern can give us an idea. So if at all it is an uncle herniation, we will see that there's a unilateral dilation of the pupil, and there may be a contralateral weakness, and the breathing pattern may be abnormal. So the most important thing is to look at the pupils as well as the motor responses. As the herniation progresses, we will see a progressive worsening of the motor responses also. It may go from something like localizing tooth pain to posturing to one side to complete decorticate posturing. So it is important. Then other herniation syndromes are also there. There is a falcine herniation in which the brain herniates below the superior sagittal dural fold. It results in monoparesis of the contralateral limb, and there is something known as an upward transtentorial herniation as well. So this happens if we have a bleed in the posterior fossa. In this, what happens is there's a loss of the vertical eye movements. What we will see is that the baby is able to move the eyes horizontally, but vertical movements are absent. There may be acute hydrocephalus and signs of raised pressure, and there may be superior cerebellar infarction. So most of the herniation syndromes will have signs of raised ICP. In addition, we need to look at the pupils. At times, there may be tonsillar herniation. That means the cerebellar tonsils will herniate through the foramen magnum down to the spine. In this case, it can result in sudden death. So any posterior fossa bleed is very, very dangerous. Any raise in posterior fossa pressures gives us very less time to intervene. So beyond this, we can look at the oculocephalic and oculovestibular responses. Now, this might not be possible in the ER. It looks at the brainstem function. We can look at the corneal response, which again can assess the brainstem function. And we should look at the DTRs also. Sometimes absence of DTRs can indicate a spinal involvement. It can be a high spinal involvement like cervical injury or a the herniation of the cerebellar tonsils, and there may be a spinal shock stage, or it may be a localized spinal injury. At the level of the injury, we might get absent deep tendon reflexes. So again, it helps us to assess the extent of the involvement. So coming back, once we have a child in ER, we should immediately ask about the extent of injury, how was the child injured, and then we have to manage immediately, look at the airway circulation, resuscitate. Then comes the indications for imaging. Now, this usually happens if the child is not having a raised ICP. If a child has raised ICP features, we are going to manage for the raised ICP, and we are immediately going to get a neurosurgery team involved and get an imaging team to find out where is the bleed. Now, problem comes when we have kids who do not have a severe brain injury. So there are specific indications for imaging in a child who presents with neurotrauma, which have been given by the Pediatric Emergency Care Applied Research Network, or the PCAN. So CT brain is indicated in any child who has a GCS less than 14, or has an altered mental status, or there's a palpable skull fracture who is in a child who is less than 2 years of age, or there are signs of basilar skull fracture, especially in kids who are more than 2 years. So we have anything like a mastoid discoloration, indications for getting a CT scan done. Now, if all the GCS is good, it is more than, it is 14 or 15, the mental status is okay, there are no palpable skull fractures, there are no palpable hematomas in anywhere on the scalp. There is no history of loss of consciousness, which is beyond 5 seconds, and there is no severe mechanism of injury that we had asked on the history. In those situations, CT imaging is not immediately required. However, sometimes kids are not acting normally. They might be confused. So in this case, it is predominantly a physician experience. So these are the guidelines that have been given by the IAP. So it depends on the physician experience, whether you want to just observe or you want to do a CT. Observation is probably best for any child who has undergone a trauma, at least for 12 to 24 hours. If there are other multiple injuries also, it might be better to do a CT of the look that, okay, there's no bleed we miss, worsening of symptoms or presence of which was early okay, is no display signs of fusion, is now becoming capability, or have developed seizures, or is having focal neurological deficits, is having one-sided weakness, there's squint, and then CT should be done. Any child who has a trauma less than age of 3 months, CT should be done. In any situation where the parents are wanting CT done, the preference is to image and see whether there's any damage. CT can be done. It is a reasonable investigation to be done. So beyond that, as we do the CT, what do we need to look at? We need to look at what is the kind of bleed the child is having. So by and large, we'll just go through a little bit of basics about how the CNS bleeds look like. So if we go from outside to inside in our brain layers, we have the skull, which is or to which the dura matter is closely adherent, which below which is the arachnoid matter. The space between the arachnoid matter, the space between the arachnoid matter and the dura matter is known as this, the epidural space, the upper space, and space between the arachnoid matter and the brain matter, which is closely adherent to the matter, is known as the subarachnoid space. Now, the name of the bleeds come from these only. So the bleed, which will be epidural bleed, it can be between and the arachnoid, then it becomes a subdural bleed, and between the arachnoid matter and the pia matter, it becomes subarachnoid. Now, we identify these. So we have to understand that the skull and the dura are completely adherent to each other. Let's go through these. So epidural bleeds between the skull and the dura. So the dura and the skull are adherent to each other, and they are limited by the sutures. So this is why whenever there is a bleed between the skull and the dura, there is no place for the bleed to expand out. That is why it will become convex in shape and it pushes against the skull. So what happens is something like this. So because the dura is adherent to the skull and there's no place for the bleed to expand out or spread out, it will start pushing like this and it becomes convex in shape. So convex bleeds are your epidural bleeds. If we have a subdural bleed, so the subdural bleed is between a dura matter and the pia matter. And as we know, they are not limited by any sutures. So it can spread along. So it is limited usually by the major dural flexure. So it can be limited medial to lateral by the falx cerebri, and from superior to inferior by the tentorium cerebri. So usually they will be limited to one hemisphere. They will probably be limited only to the supratentorial or the infratentorial part. They are not limited by sutures, so they can extend along the sutural lines. They tend to be concave. Now, how do we differentiate it from a subarachnoid hemorrhage? In subarachnoid hemorrhage, because the arachnoid matter and the pia matter are very closely adherent to the brain sutures, so subarachnoid hemorrhage will have a presence along the sutural lines or along the gyrations also. We'll just have a look. So if we had this kind of a bleed, which is by the sutures, there's some convexity, but we also see that there is some concavity here. So this is a bleed which is not limited by sutures. It might be possible that the child has a subepidural as well as a subdural bleed, but this is definitely a subdural bleed. And as we can see, it is kind of limited by the central sagittal of the falx cerebri. So this is a subdural hemorrhage. When we compare it to subarachnoid hemorrhage, it is usually involves the cortical surfaces as well. So we'll just have a look. So if we have a look here, so this is a non-contrast CT of a child who has multiple intraparenchymal hemorrhages. So we see that the arachnoid areas or the inside the sutural, the gyral patterns are quite evident. So this is a subarachnoid bleed. Again, if we look at this bleed, what we see here is there are multiple bleeds which are along the flexures, and also there is some hyperdensity along the city. So this is a subarachnoid bleed. So subarachnoid is basically very, very adherent to the brain matter. It follows our sulcations become very prominent, and they do not give a very good outlook for. Why it is important is subdurals and subepidurals are the bleeds that will need to be evacuated. Subarachnoid bleeds, until and unless they are associated with a intraparenchymal large bleed or an intraventricular bleed, will usually not be required, will usually not be evacuated. And these are the most common bleeds which are also associated. If they are large subarachnoid bleeds, again, they might need to be evacuated. So when we have a child who comes in the ER with mild TBI means that there are no signs of raised pressure, the child is conscious, there's no seizure, there's no loss of consciousness, nothing like that, then we just have to reassure parents. On the other hand, if we have a child who has any of the danger signs, we get a CT done, CT has a significant bleed, we need to take a neurosurgery consult and plan for an intervention. Many times, even with a smaller STH or a smaller epidural hemorrhage, the only thing that we need to do is management of the child for 8 hours and the child can be discharged. Mild TBI, on the other hand, we need to reassure. If the parents insist, we might need to do a CT, but most of these kids do not need CT. They may need oral analgesics for 2 to 3 days. Now, whenever we have kids with mild TBI in the ER and we are discharging them home without an observation, or let's say even if we are discharging them after 24 hours, we have to explain a few danger signs to the parents, which includes any headache which gets worse or does not go away, which is a persistent headache. There's significant nausea or repeated vomiting, which might indicate signs of raised pressure. There's increased confusion, restlessness, or agitation, which may again indicate an underlying increase in the brain pressures. Any new onset focal neurological deficits like slurred speech, sleepiness, inability to wake up, any weakness, inability to use one arm or leg, or squint, numbness, decreased coordination, they might indicate extension of the bleed or presence of new areas of bleed or worsening edema after the initial bleed. Any loss of consciousness, convulsions of seizures again become important signs. If they are present, the parents should be instructed to come back so that the child can be further interventions if needed can be done. Now, whenever we have a child with severe TBI, which means the child has got a significant injury, the child has signs of raised pressure, the pupils are unequal. In such situation, a standard protocol for all TBIs has to be first neutral head positioning, 30-degree elevation in the midline position. Other than that, in the ER, we should try to maintain normothermia. The child should not get too cold, should not get too hot. In case of pyrexia, we can start PCM SOS or every 6 to 8 hourly. Analgesia and sedation are very, very important because they independently can, and presence of pain can result in fluctuations in the blood pressure, which can again have an implication on the management of the central, which can have an implication for the maintenance of the cerebral perfusion pressures. So analgesia, if required, should be in kids many times only paracetamol can work for mild TBIs. For severe TBIs, we might need opioids and benzodiazepines. A combination of fentanyl and midazolam can also be used, but it needs to be taken care of that whenever we are using a significant sedation with benzodiazepines or midazolam, we have to keep a watch on the sensorium of a child as well, because a dip in sensorium might prompt us to evaluate further or consider an intervention at any point of time. We have to maintain a proper intravascular volume. We have to start fluid therapy. For kids, we can start at 75% maintenance. The fluid of choice is usually normal saline for older kids. And for infants and younger patients, we can use 5% dextrose and normal saline. Seizures, if present, have to have an aggressive control. So if seizures are present and the child goes into multiple seizures, the management protocol has to be that of a status. So we go with the first line benzodiazepine. If it is not working, we can go ahead with eptoin or levetiracetam. If that is not working, we might consider hourly intubation and midazolam infusion for a good seizure control as well as neuroprotection. So that needs to be kept in mind. So any signs of raised ICP should prompt a neurosurgery consult very early. If at all a child comes to the ER, the pupils are not reactive, there's an unequal pupil, we should immediately start 3% saline, get the neurosurgery on board early so that by the time our CT has been done, we should have an intervention in hand. At many centers, if the CT availability is not there, the medical management should immediately be started and the neurosurgery team has to be involved, because early evacuation or even decompression craniotomy, let's say there's a concussion, there's not an active bleed or there's an intraparenchymal bleed which cannot be evacuated, decompressive craniotomy is going to save the brain, which is not actively involved in the trauma. So that is a long-term goal. Even if we are not able to salvage the brain which has undergone a bleed, we have to salvage the brain which is normal. So decompressive craniotomy is very, very important. Bleed evacuation, if needed, should be done. So I am not going into very much detail about the various parameters that have to be maintained, because this is the ER management. Once the child is stabilized in the ER, the child is going to be usually shifted to the PICU for further management. So whenever we have a child who comes in with a traumatic brain injury and the GCS is less than 8, we should take a call. Do we need to get a CT done immediately or not? And do we need to get the neurosurgery involved immediately or not? If it is the neurosurgery is immediately involved, we can upfront see that there is a raised ICP. We can consider to put an ICP monitor, but this is not essentially an ER procedure. It can be done once the child is stable and shifted to the PICU as well. Immediate baseline care has to be appropriate sedation and analgesia. The ventilation, if required, has to be started to maintain an adequate oxygenation, and we want to maintain a normocarbia with a PCO2 of 35 to 45. Maintain a normobulimia, aggressive fluid resuscitation because the child has had a trauma. There might be other trauma to other parts as well, and we have to maintain the blood pressures. We need to maintain HP more than 7, which is the minimum target. In the ER itself, the head and elevation should be at least 30. We should use anti-seizure medicines, Eptoin or levetiracetam, whatever is available, and treat hypoglycemia and metabolic abnormalities. So important part is we need to consider brain herniation immediately. So any signs and symptoms of herniation like anisocoria, hypertension and bradycardia, which is a Cushing's reflex, or abnormal posturing, either the extensor or flexor, should immediately prompt us to get a neurosurgery consult. And we should immediately start with brief hyperventilation, can give mannitol or hypertonic saline. In fact, mannitol should not be considered a contraindication in a child who is having impending herniation. If hypertonic saline is not working, or not available, and mannitol is readily available, we can give off mannitol in the first go. If at all there are signs of herniation, an emergent placement of external ventricular drain or decompressive craniotomy should be considered. And as early as possible, neuroimaging should be done. Now, if it is if it is a raised ICP, then there are different ICP pathways in which we put a intracranial pressure monitor. We monitor the cerebral perfusion pressure, and accordingly, we can change our therapies for the management of the raised pressure. So just to conclude, I think that slide is missing. Just to conclude, the main aim of ER management for a child who comes with trauma is to assess whether the child is going to have a life-threatening bleed or not. If the child has a life-threatening bleed, is it something that is resulting in herniation? If it is early herniation, that is the time we have to that is the time that we have to intervene. Whenever the child comes in, we have to see whether the child is going herniation or the child is going to go into herniation. Not only the initial assessment, even when the child is with us for the next 1 to 2 hours, there should be frequent checks of the pupils, because a child who is initially normal in the transient stage might go into herniation. So this is the thing that we need to pick up very, very early, and accordingly decide our interventions as far as the neurosurgery consult is come. Most of the times what we see in OPs and in ERs are mild traumas. In mild traumas, we should try to assess whether this child really needs an imaging or not. Many times a child is otherwise okay, there's no loss of consciousness, there are no seizures, no neurological abnormalities, may do without a CT as well. Many times the CT, if we do it, will pick up only minor bleeds, which again need only a supportive care. So I hope that was helpful. It was quite a short session. Over to you, Dr. Nitin. Nitin sir? Sir, I have done my part. We can have any questions if they are there or in discussion.
Yes, ma'am. Sorry, was in an OPD. Just give me a second.
Yeah, sure, sir. So it was a pretty short session, but I just wanted to cover on the ER aspects of it.
Hello, sir.
So-
Yeah, madam. Thank you so much, ma'am. That was, though it is short, it is very crisp and clear message was there, ma'am. So I think this is a YouTube session, ma'am. People will watch on the YouTube,
Okay.
and they will post questions in the group itself, WhatsApp
Okay.
group. Three WhatsApp groups are there, three full
Mm.
WhatsApp groups. So I think Nitin sir will add you in the main group so that any
Mm.
queries regarding the neurotrauma and all will be answered in the group itself, ma'am.
Okay.
We request
So,
you to be in WhatsApp group for 1 week. And the questions will be, you can answer, take time for 10-15 minutes per day and take answer, just answer those questions. We won't trouble you
Sure,
much.
sure.
On the other
I
hand,
know.
it is viewed by more than 2,000 people, doctors across India. And definitely many questions also can come. But on the whole, I really, you made it simple. I know that topic is tough topic, but really it's wonderful. Thank you very much, doctor.
Thank you, sir.
Nitin?
Thank you, Dr. Prabhjot. Yes, sir.
POD talk.
Sure, sir. We will close the session, ma'am. Thank you, Dr. Prabhjot. Thank you, Pawan sir.
Okay,
Thank
sir.
you, Shri Krishna sir.
yes, sir. Thank you, sir. Thank you so much, sir.
You made
Thank you, Shri Krishna, sir. Thank you, Pawan sir. Okay.